It is time to start. Eduardo is not here, but I don't know if I should, okay, we're gonna go ahead without him. Welcome back from lunch. We have a very exciting session for you all, which hopefully will keep you very engaged. Make sure you have water so you can stay awake for everything. This third panel discussion is on advancing efficient cancer care through the care pathway with a spotlight on early detection and early treatment. My name is Darian Laird, and I'm the Executive Director of the Global Coalition for Radiotherapy. And our aim at the GCR is to increase access to safe, quality treatment for radiotherapy globally. So I'm thrilled to learn from our experts on the panel today who are talking about that, early diagnosis and early treatment. As you've heard all throughout the day, our objective is to bring discussion to the table. So our panelists have all said they want to engage the discussion with the audience. We have questions we're asking them, focusing on the challenges and the barriers that exist in current cancer care pathway, no matter where you live, related to early care and detection. We'll also address disparities in access to cancer care and early detection with an emphasis on strategies to reduce those disparities. Our panelists and experts in the field will showcase successful models and interventions that have been effectively implemented to improve access to early detection and efficient cancer care. And we are excited to spotlight the All.Can publication that has been announced and shared as well, learning more about the data and metrics associated with timeliness of care and the ability of health systems to provide and monitor timely care delivery. Just a bit of housekeeping for anyone who's joining us virtually new, please share your questions in the chat and as well prepare questions for our dynamic discussion as we go throughout. I've already loved the ideas that have been brought to the table. Michael, with your absolutely fabulous and poignant, let's have discussions and tailor our answers to whoever is at the table with ministers of health, ministers of finance, whoever is going to help us actually implement these ideas. So I will start with a brief introduction of Mariana Cavassa, who joins us from Milan, Italy. And she is an associate professor of practice and health policy and a research fellow. And her research focuses on the analysis of health policies from both national and comparative perspectives, with an emphasis on public policy organization. When I met with her last week, she summed it all up by saying, to put it briefly, we are economists. And that is such a key part of understanding what goes on in the cancer continuum and how we can improve our current system and also communicate with others. So thank you for joining us, Mariana.
Thank you.
And I'll start with a question. First of all, can you summarize for us the main strategies that you've used in the countries you've studied to enhance early cancer detection?
Thank you. Thank you. I'm very pleased to have joined this very interesting meeting. Very briefly, let me introduce the research project, which is the information source of my intervention. It's a research project that was conducted within an initiative that is going to be launched on Wednesday within the World Cancer Congress. And the goal was to identify strategies or solutions used in countries with policies, environment conducive to early cancer care, and by early cancer care we mean a multi-step process, including education, so health literacy and awareness campaigns, and then early detection, early diagnosis, and at the end, a prompt early treatment. So just we ranked 32 OECD countries using a prototype, let's say, of a composite index, just for measuring how policies of these countries were conducive to early cancer care. And then from this we selected 3 countries for in-depth case studies. They were Denmark, the Netherlands, and Italy. And last, we also analyzed 2 countries with less advanced policies, just for understanding the challenge that they are facing. So moving to the contents, to the findings. The first key message I would like to give you is that it's about a vision rather than a strategy. That is a vision that, according to our evidence, really it makes a difference in a country. I'm talking about the understanding by policymakers, but also healthcare managers, and in some cases also by healthcare professionals, that early detection is just a part of the whole wider process that I mentioned before. I mean, including, so it's just a part close to education on one side and diagnosis on the other side. And so it's really important to have very clear this vision, that it's a process. I know I'm an economist. I'm about healthcare management. I'm very fond of process, but really here it works. It makes sense. And so let me quote an interview I had with a director of a cancer screening program in a high-performing Italian region, expressing her frustration because she is still is sometimes required to explain to the new policymaker taking the regional government that their role go beyond just sending letters and managing diagnostic exams, but their role is to be part of a process whose success is ensured when continuity and timeliness are compliant with the case. So that's really that's the core business in their mind, and the challenge is to give a message to the newcomers. Okay, that's the point of their activity. Moving to strategies and solutions. A first key element supporting this vision is a widespread information system, an information system connecting all stakeholders involved in the process and tracking, instead of privacy issues, the pathway of the participants to a screening or the patient of AGPs, and then moving towards diagnostics, exams, or early treatment. So that's really necessary. Otherwise, if you don't have a broad vision of the whole process, it's really difficult to manage and to understand how you are working. But for doing that, it's also very, very important to have also a system feeding a set of KPIs shared by the community. That's very important. And because these KPIs help you to monitor what is going on, of course, at the top level, but also it's important tracking, okay, the patients. But the point is, especially to you, I think the further step is to teach clinicians, healthcare managers to use the findings coming from these KPIs. Really, that's very hard because that's my job. Okay, I do that. I have meeting with clinicians, showing them KPIs from their activities. And usually the first reaction is, that's not me. Okay, no, stop it, keep calm, carry on, and reflect on your daily activity. And this is just a way to improve. Of course, they call a quality improvement cycle, okay, the organization scholars, but really it works. And so these are useful for clinicians, these are useful for managers, and I think it's very important training to teach them to use in a peer way. Okay, that's not an assessment, that's not a judgment, but then they are also useful for policymakers for taking evidence-based decision-making process. That's it. I mean, just a big challenge.
Well, without revealing too much, can you share a little bit about that evidence that you
Yes.
found for individuals and healthcare professionals? I mean, it's lovely that you're talking about this grand vision
Yes.
and this messaging.
Yes.
But yeah, let's
yes.
get a little bit in the
Moving
details.
towards on the details. Well, moving on details, I think another big challenge, it's and very interesting initiative is the use of clinical pathways by primary care professionals for catching, for guiding their patients with suspicious symptoms of cancer. And these pathways are designed to streamline these patients from the primary care to the secondary care. And because here the point for the issue is that usually cancer care is just, how can you say, an issue of the secondary care. And primary care is a little bit neglected. And so it's interesting, for instance, that in Denmark, they conducted training or refresh to recognize suspicious symptoms of cancers involving GPs, but also family or community nurses. And they were also figuring out to involve pharmacists working in the community pharmacies. So a very wide range of professionals that usually are not at all involved in this type of activity. But let's remember that literature says us that usually the most part of vulnerable people, meaning people, low-income people or people with low education degrees, access to healthcare services through primary care setting or unfortunately through emergency room. And so it's really, really important to invest on this area, and usually it's neglected. It's neglected, and it's also, to some extent, let me say, a responsibility of the specialists that they don't care. Okay, and then the following step is to bridge the relationship between primary care and secondary care. And again, I think it's interesting, the experience. I mean, it's very challenging, but very interesting experience conducted carried out in Denmark, where they set up diagnostic centers just dedicated to take these patients coming from primary care setting, and so also serving as a single contact point to the secondary care. That is another big challenge and key issue to keep in mind. Thank you.
Thank you so much, Mariana. And we are going to dive into a little bit more about the underserved communities that need this early diagnosis. But first, we're going to get to Antonella Cardone, CEO of Cancer Patients Europe, to my right. She is a passionate patient advocacy expert and also advisor to the board of Pancreatic Cancer Europe, and for 25 years has been involved with nonprofit work, bringing together the medical and advocacy community, and has been a big part of this project that Mariana has mentioned. And so I'll leave it to you to talk about that patient perspective. And I'll start by asking, could you elaborate a bit on the current disparities in access to early detection services and screening methods within and across member states, and what Cancer Patients Europe is doing to address this?
Thank you for inviting, first of all, the patients directly to present their voice and their opinion on the report, and for being part of this of the advisory committee of this project. Early detection and early care are crucial for cancer patients. Just a few data. If we look at breast cancer, 98% of breast cancer patients could live 5 years or more if breast cancer, if their cancer is detected at an early stage, compared to 5% of these breast cancer patients surviving 5 years or more if the cancer is detected at a later stage. If we look at lung cancer, 65% of lung cancer patients could survive 5 years or more if the cancer is detected at stage 1, compared to 5% of lung cancer patients' survival rate if the cancer is detected at a stage 4. In this report, we also found that, and it was already mentioned in the panels before, that there is a problem with the data, with the lack of comparable data. So it is not only a matter of having or not having the registries, but also having registries collecting data that then can be compared. And also, there were mentioned some countries that are particularly virtuous when it comes to early detection. Denmark was mentioned, and but then also countries where early detection and early treatment are exemplary. Still, if we look at the entire cancer care pathway, there are some huge gaps. For instance, in the Netherlands, that is considered a country where early detection and the screening programs are very good. Still, when it comes to access to new medicines, only of all the new medicines available in Europe, only 44% of the EU-approved medicines are available in the Netherlands. And in Denmark, there is, if we look at the time of access to new treatments, it takes almost 900 days to access a new medication, compared to 400 days, the average in Europe. And there are also countries in Europe, like Germany, where a new treatment is available almost on day 0 after the EMA authorization. So when we look at what Cancer Patients Europe is doing in this context, I can mention, I mean, we are doing many projects, but one is particularly significant in this context, and it is a project that we are doing on promoting on the European Semester Manifesto. So the European Semester is a European Union's annual framework to coordinate economic, fiscal, employment and social policy within the European Union. Health is not included. So we strongly believe that health should be included in the European semester. So we are working on, we have published and launched already a manifesto together with CCOG, which is a network of a cooperative of oncologists trying to train oncologists from Western Europe into Eastern Europe. So we are trying to bridge this disparity between Western Europe and Eastern Europe through the European Semester Manifesto. We have launched this manifesto with several MEPs in the European Parliament before the election. So now we plan to approach the new elected members and push for the inclusion of health in the European semester. I think I will stop here.
Thank you, Antonella. Thank you for all that you're doing. I mean, I wasn't going to mention this, but my mother-in-law was diagnosed with breast cancer 2 weeks ago. She is in that 98% because she's meeting with her doctor tomorrow to have a treatment plan. Detection, early detection, and early treatment is a gift. It is a gift that we, as a community, can help provide. And so thank you for the work you're doing. I'd love for you to dive into a little bit more health literacy and how that impacts patients and making sure that they get that early detection.
Yeah, we've heard before in the previous panel as well that there are huge differences in approaching prevention depending on the demographic and cultural, educational level of the citizens. So there is already quite a large evidence on the impact, on the positive impact of health literacy on essentially on prevention and early detection. But I also can mention some activities that we have done as Cancer Patients Europe. Like we have done a survey the survey was specifically on breast cancer and genomic testing. And as a result and we did this survey in UK, Spain, France, Italy, and Germany. So countries where genomic testing for breast cancer is available and reimbursed. And the answer of this to the survey of these women was that 4 out of 5 breast cancer patients eligible for genomic testing were not told by their oncologist that genomic testing was an option. So we tried, so after this striking news, we tried to understand better what the cause of this could be. And so we tried to understand where women want to get the information. And so the vast majority of women would like to receive the information from their oncologist. So they don't go online. So or they go online only because they do not receive the right information from their oncologist. And so we started to work more with oncologists, so trying to put together patients and oncologists around the same table. And we have organized 2 workshops, and so to try and understand how shared decision-making can be implemented. Of course, the patients say that shared decision-making is not possible because the oncologists are not educated and trained enough. On the other side, the oncologists say that shared decision-making cannot happen because patients are not health literate enough. So now our plan is to try and work on both sides. So with the patients, we are putting together materials, fact sheets to train them, and starting from raising awareness on those conditions that are rare But then also we are starting to work on patient decision aids that can help enhancing health literacy. And the other thing is that, I learned yesterday from an oncologist. He told me that I should know that doctors never change. They either die or retire. So we are on this space and trying to approach oncologists and see how we can work together.
Thank you. I will assure you that I do work with some oncologists that are very eager to change and learn. So I think they'll take your advice. Especially in this room, we work with a lot of those. Thank you so much, Antonella. And this leads directly into our lovely Leah Stevenson. Thank you for joining us from All.Can Canada. And also, I was very touched last week when we met that you shared about your personal experience coming to this work, being a caregiver for your late mother and watching her as she, as a physician, was also battling a lot of the barriers that come to underserved communities, and that has really had an emphasis on the work that you've done. It is clear that her battle is ongoing through your work. So we're pleased to have you here. Thank you for doing the important work that you're doing in Canada. And if you could bring it a little bit more micro for us, taking a look at a country, even though Canada is a very large country, but large, a large diverse demographic that you can share with us. What is the current state of cancer diagnosis in Canada? And also, in your analysis, what is an optimal future state of early cancer diagnosis? What we can look forward to.
Thank you so much, Darian. Yes, I really appreciate that introduction. I have been working for about 20 years now in advocating for health system reforms, usually with patient groups from the perspective of people trying to use the system. I've also worked for a number of years with equity-focused primary healthcare teams. And I didn't plan. It was synchronicity, but I have lived experience, as you mentioned, as a daughter. My mother was a physician, and so knew the system extremely well. But she passed away from a late diagnosis so it was recurrent endometrial cancer, completely curable had it been caught at an earlier stage. So it was complete synchronicity and kismet, or whatever else language you want to put, that I was given the great honor and privilege and opportunity to work with All.Can Canada, which is a network, multi-stakeholder network, one of the many national initiatives supported by Save Your Skin Foundation, working with patient groups and stakeholders across Canada, trying to improve the efficiency of earlier cancer diagnoses, which was the part of the continuum that we chose to really hone in on because it's a complex, fragmented system within Canada, and there isn't as much attention being put on the earlier diagnosis side of things. So at least, and I'm sure some of the things that I'm sharing here will resonate across borders. I would be surprised if they don't. And I don't know if I can change this slide or not, but there's a picture I'd like to show you if I can.
Did we get it?
No, that's the one. Sorry about all the little, this is a draft, but you can see we did a little bit of homework, and there's some new pieces in there around equity and structurally underserved communities that are still draft. But I'm sharing it. You guys are getting a live world preview on some of those factors that we've been hearing about through our last roundtable on equitable cancer diagnoses. But in Canada, most cancer diagnoses are coming from the point of symptom presentation. So we honed our research, mixed methods research, in from that point of a patient experiencing some kind of concern or symptom, trying to interact with the healthcare system, to the point of their getting a diagnosis and treatment. And so what we learned was the current state is on the left-hand side, what some people call, I didn't call it this, it was named by others, the spaghetti map. It's also been called snakes and ladders because one can slide from one part of the mess to an earlier part of the mess. In Canada, and we found that there was 3 parts to the trajectory, and the first part is that symptom piece. And in Canada, you do need to go to a family physician or a nurse practitioner in order to receive a referral to investigate, a possible symptoms that might be cancer. And so there's a few different issues that cause delays in there, and people are literally circling around for months to years in that first, trying to get that first referral, trying to get, or maybe not trying, because maybe they don't want to think that what they have is possibly cancer. That often is the case. But one of the first issues that people are hitting is access to primary care. We do have issues within the country about primary care availability, and some of that is being driven by payment models and by practice models. It's estimated by the Canadian Medical Association that up to 30% of current family physicians in Canada are not practicing in community longitudinal primary care settings. They are avoiding the mess of the current sort of practice and payment models and staying in hospitals and other specialized clinics instead of working within primary care. So there are many Canadians that don't have access to with an ongoing primary care relationship. So they will then be using walk-in clinics or now with post-pandemic an uptake of virtual care. But we also have digital inequity issues. So some people don't have good connectivity even. So access can be your first point of challenge. But then as people are cycling around, often they find they're presenting, to the earlier point, they're presenting with symptoms that could be many different things. So they aren't getting, the cancer question isn't coming up quickly. They're often being misdiagnosed, sometimes misprescribed. They're often going to other types of providers, allied health, naturopathy, complementary therapies, in order to try to deal with the symptom or have other people take a look at it. As things worsen, they'll go to emergency rooms. And then eventually, hopefully, finally, they get that first referral for investigation. And then they're moving into the next phase, which is the investigation phase. And again, they're navigating through a maze of specialists, laboratories, hospitals. Generally speaking, these are disconnected, independent bodies or units. They're not integrated. There's no interoperable health information, so the patient is the source of informational continuity. There's questions about who's coordinating. Usually the answer is the patient or the family or caregivers. When they're going to different tests, how do I prep? What's going to happen next? What will the results be? If they have a family physician, do they know the results? There's often poor communication between the providers and themselves, and between the providers themselves, since there is poor health information systems. There is that distress that kicks in for the patient and often for family and loved ones as well. As soon as the cancer word is mentioned, that we're going to investigate you for a possible cancer, that can induce a degree of distress, and there is rarely any form of support or referral for support to help people cope with that distress. And then, as mentioned earlier, people can often fall through the cracks. We have, a fax gets sent and the paper falls down through to the wrong place, and now you have to go back and see the primary care physician again to get re-referred. So self-advocacy is driving a lot of how the fragmentation is being addressed. The coordination and self-advocacy is falling on the patient and the loved one's shoulders. And if you don't know what you're advocating for, or if you don't have the sense of agency to do that kind of advocacy, then that can be really problematic. And I think generally it's seen as a symptom of problems within the system, not as a source of strength. And then in the final phase where diagnosis takes place, after diagnosis happens, there's the pathological and the therapeutic pieces that need to happen. And again, and oftentimes now, there's the whole genetic piece that's really important there. And there are huge access issues on that side, particularly on the genetic therapeutic diagnosis. And when you are able to access it, there's huge variability. So turnover times ranging from 1 week to 2 months, and at 2 months it's no longer clinically relevant, and then huge issues around reporting as well. So some reports being very clear and actionable and comprehensive, others leading oncologists to actually prescribe the wrong therapies because they're so convoluted or lacking information. And so this can also result in further delays. And then, as mentioned, we're starting to learn more about what does this look like, and what are the challenges for structurally underserved communities? In Canada, that includes First Nations, Inuit, and Métis communities, who often are very slow to enter into the healthcare system at all. And once they're there, they often experience harm and leave it again. So there are numerous buckets of challenges happening there, and the harms and the distrust can be coming from basically who they are, the various, or how they're perceived, the various isms that we're all familiar with. So ageism, which can be, oh, well, you're too old, so we're not going to treat that form of cancer, or you're too young to have that kind of cancer. There can be the stereotyping associated with a First Nations person presenting with pain. There can be language barriers. There are poor social determinants of health at play. For some people, it's a choice between going to that appointment and paying for the groceries. Some people are housing insecure or outright homeless. Trauma and intergenerational trauma play are big factors. What happens within communities that are experiencing intergenerational trauma is that even if they haven't touched the system themselves, they know of all of the harms that have happened to their family members through sometimes generations. And so there's huge reticence to touch that system. And once they are in there, how their trauma is manifesting can be misunderstood as well as anger or other types of problematic, quote unquote, behavior. There can be cultural stigma. There can be generational factors. So, older patients perhaps not being willing to ask questions because it's just not a comfortable place to be. The good news is, there's a better future state, and I think there's themes that have been forming through the day. So some of this is going to be a bit of repetition, but high-performing specialized teams that include navigation, and that's at the level of primary health care, at that level of investigation, and then once you're into treatment. Pathways and protocols that include, thank you so much for naming this, Mariana, symptom pathways that are helping primary care providers and emergency room physicians be able to more rapidly go through the differential diagnosis process and ask the question, could this be cancer? For example, people presenting with chronic cough over 3 weeks, over 8 weeks, take your pick, there should be, and I think there are some examples out there. I know of one in the UK where create with primary care into the secondary and tertiary care, that pathway from that point of symptom investigation. And then those rapid referral mechanisms, as you mentioned as well. The need, and again, this is a theme, interoperable health information. The PROMs and the PREMs as well, once you've got interoperable health information that's high quality. And then I'll bring in the piece around the need to do the data disaggregation as well. So in order, you can look at that big global number and be like, okay, we made a lot of improvement, we're doing great. But then if you're looking at it for particular structural inequity, whether that be age or income or ethnicity or whatever the case may be, geography, rurality, you can start to see where's the variation happening in the population. Where do we need to do some different targeted interventions? How are we doing? Are they working? Et cetera, et cetera. In a future state, we have compassionate communication is the norm. And there's proactive explanation of the pathway. Those pathways exist, and people tell you what's going to happen next. Psychosocial support is integrated very early, and community resources like patient groups are made available, and you become aware of them very early in the process. Healthcare providers and policymakers are trained so that they're able to work in such a way that they have the skills for cultural humility. They're trauma-informed, they're trans-informed, and they are a diverse workforce so that people are gaining trust by seeing themselves in the healthcare system. Funding is flexible, it's integrated, and in Canada, we need to really scale and normalize, and I'm hearing from the earlier comments today, everyone's needing to scale and normalize a lot of the promising and best practices that are already at play. And that's an equity issue. By not scaling and spreading what's working and adapting it to different parts of a country or a system, that you are creating inequities. One is creating inequities. A gap that we're finding is in that primary care provider support with differential diagnosis. And we're very interested in concepts like common symptom pathways and any other great ideas, and would love to learn from all of you about any international examples. And we're diving deeper into the whole piece around equity and different structurally underserved communities and how to promote earlier cancer diagnoses amongst them.
Thank you very much, Leah. And if we could get a snapshot like this of every country, that would be incredible. So it's a spaghetti mess, but we need to know.
It's a spaghetti map, it's a
We-
future
yeah.
state, and these are some of the practices that we're finding or frameworks that are helping us get from one to the other. All the stuff that exists, it needs scale. They're little pockets of excellence, you know? Let's make them the norm. And then the ones that are not bolded, for us, they're gaps and they're areas that we see opportunity. So.
And that's where we're headed to next. Professor Jesus Garcia Fongias. Thank you for joining us. Director of the University Cancer Institute and Department of Oncology, and also the president of the ECO Foundation, Fundación. Thank you. I could spend 5 minutes talking about him, but I'll let you dive right in. Could you tell us a little bit about the Optimal project and the efficiencies that you're finding there?
So thank you very much for your kind invitation and your interaction. So I'm president of ECO Foundation. It's institutions focusing on looking for fostering quality in cancer care. And obviously we go back to the title of this session, optimizing efficiency for better care. So we can see that something that we have conducted in our foundations during different hospitals in Spain should be how we're able to increase. Don't worry. I don't need it, okay? So something that we are looking for should be how to improve efficiency in oncology care. So it's not only to talk about efficiencies as well, to talk about safety, quality of life, and cost-effective approach. So if we take a look at what is happening in Oncology Day Hospital, we can see, so first of all, that very often we can see a patient's appointment is manually scheduled. So because one of the efficiencies that we have identified should be poor resource utilizations. Pretty often we can see as well delay in lab results, and obviously it means extending hospital stays, and we need a different approach for blood collections and analysis. So we have limited consultation times, and it means that very often patients wait for medical visit very often in the hospital. So we need to improve the efficiency of medical visits, and very often we can see as well the lack of electronic prescriptions. So, and something that happened after prescription could be the lack of confirmation of the schedule about the treatment that the patient have to receive. So obviously it means that we're losing chores that must be used in the Oncology Day Hospital. And it's true that in terms of preparation of the medications, we can see the pharmacy capacity constraints. So obviously we need an electronic system because we're suffering, and the patient suffers delay due to the manual processes and distance between pharmacy and Oncology Day Hospital. And talking about the administration, the treatment, very often we have limited staff, and it means delay to poor synchronizations, lack of electronic identifications, and the lack of smart pumps. So at the end, something that happens very often, a bottleneck, limit nursing availability for documentations. So we continue, and our nurses continue to use manual documentations. So it means that we're reducing time for patient care. and obviously it's a potential role for automations and for implementing electronic systems. So something that we have seen in this clinical project conducted by our foundations in different hospitals in Spain, that the introduction of new technology, the most viable and cost-efficient solutions to reduce waiting times. And it's something that we have confirmed in Spanish Oncology Day Hospital as well. We're able to improve patient safety. And we need to computerize the processes from prescriptions, preparations, and administration. And it means that we're able to minimize adverse effects throughout the process. We're able as well to reduce waiting time by 8 days in our own statistics, and we're able to generate an estimated saving from the Spanish health system, not only in cancer, and as well in other different specialties, more than 2,000 billions. So it's a huge saving. So obviously we need to introduce new technology to improve patient care. So it means an option for enhancing quality care, to reduce bureaucracy, to improve professional well-being and job satisfactions. And something that we need clearly to point out should be medications traceability systems, including e-prescriptions, e-preparations, e-administrations, because we need to foster in most effective technology for reducing bottlenecks, and not only inefficiency, and as well patient safety and quality of life for patients.
Thank you very much, Jesus. And I apologize, I'm not doing a very good job at the slide. I'm not doing a good job at the slides or at the timekeeping, but I do want to take just a moment for us to bring up the Mentimeter question. And if there are 1 or 2 questions that people would like to bring up to our panel. Do we have anything from the chat? No?
See Richard
Oh,
with
Richard,
his
yes,
hand
please.
raised.
Yeah, I thought, Jesus, you're, of course, right about bureaucracy in healthcare. We hear that a lot from professionals. I just wondered, in your own practice, would you identify sort of examples of some of the things that cause you to have less time with patients, the forms you might be filling in? Is it related to the health records or other examples?
Right. So I think that it's something that we have seen previously to implement this new clinical resource, that in different hospitals doing something like a query about what are the bottlenecks. We have seen that we have several crucial points where the patients is delayed, and it means that sometimes perfectly that currently in our cancer centers, our patients wait for a long time from our first visit and to even to the end of the therapy. And as well, very often we're not using very efficiently our resources. And even we have sometimes more resources that we need, or maybe we have not enough efficient use of these resources. So we can see that we're able to manage much more efficiently, and we can use these resources because we're able to reduce those bottlenecks that has been previously identified. So we can see better outcome, not only for the patient, as well for all the people involved around the cancer patients, and even for the system, because we are losing many resources and even more. So very often we can see we're able saving in terms of medications. So I think that at least in our country we have seen that we need this kind of different approach for handling much better. And something that happened that we have seen as well, so the possibility of reducing adverse events and medication errors, because patient safety is a crucial step for any organization. And it's something that has been included right now in the new system based on the Comprehensive Cancer Center to the reference center. And this center, right, my institutions, we need to work much more efficiently for using the resources that we have for different duties that were not applying correctly.
Thank you very much. And as we can see, there is a gap here. I mean, early cancer diagnosis and care is not prioritized. There's an opportunity to improve the bottlenecks, improve the cancer pathways, especially in that early stage. I'd ask for each of our panelists to give us, as Eduardo has asked us so aptly, to have a takeaway. If you could have one 30-second takeaway to give to each of us. Mariana.
Trust.
Trust.
I think really trust is a big challenge. To build up trust in citizens, to go to primary care professionals as they have perception of some possible symptoms. After a wide health literacy, education campaigns, etc. That's not only an issue of accessing to screening, but also to recognize symptoms. But you need trust for that.
Thank you. Antonella.
Well, for me, it's essentially implementation. I would say we have now enough evidence. We have all the evidence that we need on all different aspects on how important is early detection and early cancer care. But we need to implement what we have. And actually, I would say we already have a very good plan, Europe's Beating Cancer Plan. So I would really like to see the end of the implementation of Europe's Beating Cancer Plan now.
Thank you. Leah.
High-performing, culturally humble, interprofessional teams that include navigation and psychosocial support in primary health care, during investigation, and once you're into cancer care and beyond, or integrated practice units in value-based healthcare language. Pathways from the point of symptoms with rapid referral mechanisms, interoperable health information that promotes a learning health system, and it includes PROMs and PREMs and data disaggregation, such that structural inequities are understood, acted upon, and equal outcomes are achieved. And overarchingly, and towards that piece around trust, at the micro, meso, and macro levels, co-design that includes people with lived experience, including those from structurally underserved communities.
Thank you. And Jesus.
So, patient safety and cost-effective use of the resources that are available in our own environment.
Lovely. So what I'm hearing is a foundation of trust, co-created, so that we can have patient safety and we can implement it. And we are the people to do it. I loved what Eduardo said when we all met last week, that we all have the same goal. This is a community that really wants to take action, and we can take it. So thank you all. Thank you to our panelists for joining us. And for the question, thank you very much, Richard Price, for that. And we'll have a very brief break to introduce our next group. Thank you.
So just settle in and dive right in, just in the interest of time. So let's dive right into our next session. So my name is Alex Filichevas. I'm the Executive Director of the World Bladder Cancer Patient Coalition. I'm also the past president of All.Can International too. And I have the privilege today to moderate this discussion on advancing efficient cancer care through the care pathway, through optimization of care and patient choice lens. And we are here to explore one of the most important dimensions of cancer care as a patient advocate for me, that patients are at the very heart of the care pathway in our healthcare systems, making sure that the care is more efficient, equitable, and aligned with the patient needs. And patient-centeredness is a fundamental shift in how we approach healthcare delivery, and it is wonderful to see that shift over the last few years already. And as highlighted by All.Can, inefficiency in cancer care often stems as well from the failure to focus on what truly matters to patients. And one stark finding from the survey that Christabel mentioned this morning that we've done a few years ago, and I always like to go back and to refer to some of the findings there, because we did have 4,000 respondents from 10 countries share their experiences, and most of them reported inefficiencies across the entire cancer care continuum. In the survey, we also saw that 47% of respondents did not feel sufficiently involved in their care, about their treatment choices, and broader care, which can also lead to decision regret and poorer health outcomes too. So these inefficiencies also represent missed opportunities to improve both patient experience and patient outcomes. And again, in the survey, we saw that a quarter of respondents experience most inefficiencies during diagnosis, which is a critical element of care where patient enters the healthcare systems. And then there was also an element of shared decision-making that we have seen as well in the report, as we explore different dimensions of the report through the program today. And so implementing these patient-centered practices remains a challenge, of course. We have in many systems, although in the action guide, there has been some highlights that I quite like to see in terms of patient reported outcomes and the systems in place that were sort of there or regionally or partially applicable already, which is within the All.Can community countries. So it was really great to see that, but most countries only are in those pilot stages, as I say. So this highlights a gap for us between the intent and implementation, and I think this is a good opportunity for us to continue with these discussions. So today, as we move through the discussion, we will explore how we can address these gaps, optimize care pathways, and scale up local successes as well. And our panelists bring diverse experiences as well from across the different healthcare landscapes and countries as well. And I'm really eager to hear from your insights on making patient-centered care more actionable and embedded into our healthcare systems. So with that, I think there was some guidance for housekeeping for everyone who's might be joining us online just now, and for everyone in the room too. And we will get started with the initial thoughts and present input from each of our speakers. And Dr. Hadi Mohammed Abu Rashid is the representative member of the Qatar Cancer Society in the National Cancer Governance Board in Qatar, contributed extensively to the Gulf Federation of Cancer Control, the UICC, All.Can International, of course, and much, much more. So, Dr. Hadi, what are the Qatar Cancer Society's initiatives for optimizing care for people living with cancer?
First of all, thank you so much for inviting. Thank you so much, guys, for inviting me. And it's been a long journey with All.Can, and I learned a lot. Qatar Cancer Society learned a lot. Actually, hopefully we'll be bringing the whole concept of efficiency to cancer governance and control in Qatar. So first of all, I have to do this disclaimer of thank you for the knowledge translation and so on. Regarding optimization of the care, what Qatar Cancer Society has been doing. So we've been focusing on and I like the map. Really this is the map. Kind of what we did as Qatar Cancer Society to optimize the care. The same kind of map. We sat down with all stakeholders and the Cancer Control and Cancer Governance Board in Qatar, and we defined where are the area that we can optimize care, and we found there is a area that's related to more to public education, to focus more on the instead of the Minister of Health and other players, they are focusing on the NCD, want to focus more on early detection, sinus symptoms, recognize the cancer early at the public level, and also for the patient, for education for the people living with cancer, their family, the more information about the disease, putting their questions and need, and there is a very important need, going through journey of cancer, and I think maybe All.Can, they don't know this. This is first time to say it. I'm actually being diagnosed in March with neuroendocrine tumor. I'm going through treatment. It's something. You don't need to know everything at the same time. That's what we meant with we start to know the patient. We start to understand I don't need to bombard the patient with the information. So we work with the caregiver and the people living with cancer. And also the other gap is the psychosocial need of support. And that need to be done. And in which aspect, how much support in every step of information at this, let's say at the time of the early, when suspect the cancer, how much they need support they have during their treatment, how much support they have from them, from their family, and what about when they go back to the work. So we start to optimize that level of the care, work with the government aspect, the Ministry of Labor's, Ministry of Education, when they get back to the work, how they creating better work environment, even throughout the work, so they have let's say the longer paid leave. They can, skip work to go attend their children treatment if they have children living with cancer. So that's at the level of the advocacy, and going back also at the grassroots level, working with the work environment and the schools, how they understand hosting back people living with cancer, going back to the environment. So those are the aspects that and also other aspect. Is we benefit from the digital transformation. I know if I'm gonna mention this, you're gonna shoot me in the head. COVID. We learned from COVID. COVID has a silver lining. We really kind of built in on the digital transformation, and that we start to have one of the thing in the GCC or in I would say Eastern Mediterranean region is the stigma, cancer stigma. People will not show up for support group easily. It's take a lot of effort for them to come up and attend a support group or listen. They have this stigma, and the come up in the perception, and adding the digital transformation to it, we start to be really successful. And I'm not talking about that. It's being replicated also in the GCC, is using digital transformation. I understand the access to technology may be different, and there's an equity aspect, different part of the world, but that helped us in the region optimizing care. And that digital transformation, it's not only in that aspect. We work also on the level, as a Qatar Cancer Society, we work at the level of financial toxicity of cancer treatment. We have a financial support group program, and also we brought this digitalization of having all of that process of financial support of treatment costs all through the tip of their phone. It's an app. They can submit all the requests. So that's made it easy for the people living with cancer going through that journey to have access to the patient support program or financial support program to overcome, to forget about the financial aspect and to focus on other aspects of their journey.
Thank you, Dr. Hadi. And we will initially have opening statements from everybody and diving in the discussion. If you have any questions as well or any comments that you would like to share, so that will be a good opportunity to do that. So we'll move on to you, Dr. Juan Gabriel Gay Molina. You are a medical doctor from Anahuac University and the founder of All.Can Mexico, as well as the founder and CEO of TIS, a consultancy firm specializing in health economics and health policy in Mexico, but also broader in Latin America. Indirect costs for people affected by cancer is a big part of financial toxicity that Dr. Hadi also just mentioned, and that definitely does not receive enough attention and support. And you've done a report on this very topic in Mexico. So could you tell us a bit about why the study was conducted and what were the findings?
Thank you. Yeah, thank you very much, Alex. Thank you very much for All.Can and inviting me to this talk, and especially for Alex that has done a great job organizing this session. Well, the idea of this project in Mexico doing indirect costs is there's very limited information in Mexico about what were the indirect costs of cancer in our patients, and there was a feeling that the information, there was not enough data in order to estimate that, and there's been indirect cost has kind of been undermined in decision making in policy, in cancer policies in Mexico. Even includes also actually the health technology assessment guidelines in Mexico specify that we should only focus on direct cost and no cost on when it comes to the patients or the caregivers when the treatment is going on. So we try to challenge that. Thank you very much. We tried to challenge that and see if we could have information. We basically did a secondary data did a broad systematic review, trying to find information about cost. We identified 5 different types of cancers and tried to see if we, using that secondary data and demographic and epidemiologic information from Mexico, from official sources, we could get close to estimate the indirect costs. So we focus on labor costs, we focus on the cost for the family members, for the caregivers, for the public system indirect costs, and also for costs related to premature death. And we took all that information together, and just a quick glance of the results. Of course, it's a very important sum of money. We model we modeled for 6 years of the possible cancer cases for these diagnoses. But the most important thing I think we found is that the huge burden of indirect costs comes from family members and caregivers, and it's not a small amount. We estimated that it's in 6 years only these diseases, these 5 type of cancers, and all the incidents, all the new cases that will happen in the next 6 years, is going to take about $1.2 billion in 6 years. So it's a huge amount of money, but what I think is really concerned about efficiency and patient decision maker is that almost 40% of these $1.2 billion come from the pocket of the caregivers. So our question after the results is, how patients are changing their decisions to avoid this kind of cost, and if they're missing a treatment, if they're complying with the treatment because of all these costs that they're facing by not being present at work or having to pay for the transport to the clinic. And I mean, there are more details on the results, but we found that especially the population in Mexico is divided whether you have Social Security, if you have a formal job, and if you don't have a formal job, you don't work for a company or the government, and you work by yourself, you don't have Social Security. And this impact much more in the population that don't have Social Security, because you don't have if you have to skip job, you won't get covered for that. So what going to the the efficiency of the treatment, I think it's very important to take into account on efficiency that it's also the cost for the patient and direct cost for the patient that change the relationship between cost and outcomes.
Thank you, Juan. And we'll come back to that, but next I would like to invite Elena Micheli to share your perspectives as well. So Elena is a pharmacist by training and holds a Master of Science in Nutrition and Dietetics. I should have checked this beforehand. She currently serves as a Deputy Executive Director of Medical Nutrition International Industry Organization, aiming at integrating nutritional interventions in cancer care for better outcomes. And so, Elena, we spoke a bit previously as well, and you said that there's a recent World Health Organization report that notes that appropriate nutritional care helps cancer patients cope better with their illness and treatment. So, through the lens of care optimization that we are discussing here today, can you illustrate a little bit the role of medical nutrition in cancer care, and perhaps what medical nutrition actually is for some of us who might not be fully aware of that, and what are some of those essential aspects that need to be addressed for patient outcomes from that perspective? So over to you.
Thank you, Alex. Good afternoon, everyone. I'm Italian, as you can guess from my accent, and I want to talk about food, of course. It's a joke, of course. I want to talk about nutritional care and medical nutrition. I understand in this context, so far we have been talking more top line, I would say, about cancer. And now I'm really addressing perhaps niche argument and topic with you. And what I would like to highlight today is it is really important, and I've heard different words today, like timely access, vision as well, and I understand when we discuss as well about nutritional care, these are the same topics that come out. So I see through this report, it was this guide today really highlights how topics and problems and gaps are very common in all areas of cancer. So in the specificities of nutritional care, yes, thank you. How do I move
Just the
forward?
green one, yeah.
Yes. Well, perhaps before I talk about medical nutrition and nutritional care, perhaps one step back. So what is malnutrition in this case? So malnutrition occurs where the patients are not getting the right nutrition in the right amount at a given time. So there are some nutrition insufficiencies that arise. It is very common that cancer patients lose 10, 15 kilos sometimes, and it's normal. It's considered normal, but it should not. If you consider the average is 1 in 3 cancer patients are malnourished, but in fact, there are cases, for example, if we check prevalences of different types of cancer, we can have 50% for upper digestive cancer type, 45% for head and neck. So it means 1 in 2 cancer patients are malnourished. What does that mean in practice? So the consequences of that is that patients experience sarcopenia, so muscle loss, cachexia, they're weak. They're weak, it means they cannot tolerate the therapy, they have to stop the therapy, there is an increased toxicity of that, there are higher complications, risk of infections, longer hospital stay, you name it, and increased mortality even. So what can we do about that? So there are many clinical evidence that support that. I'm happy to share with you what it can do. If you provide adequate nutritional interventions, this can support patients to respond in a better way to treatment. And unfortunately, malnutrition in cancer is neglected so far, or not well recognized, but there are many steps that we could do to improve the situation. And I go into more practical aspects now. For example, we could have malnutrition screening at the very early stages of diagnosis as well. We've been talking a lot about screening. Cancer screening is different from malnutrition screening because this happens already when you have a diagnosis of cancer, of course. And for me, a very key point of all the discussion that we had today is the integration of multidisciplinary teams in cancer management. So there should be a way that the healthcare systems provide cancer patients with the practical aspects of how managing the disease. And it was very interesting to hear that, of course, we cannot bombard the patient with information, even though it's important to provide informed choices to patients about what are the other aspects that can support their health. For example, psychological support, nutritional support, etc. And I strongly believe that this can make a huge difference, and this is evidence, I would say, it's not only my opinion, in not only in their quality of life, but also in the health outcomes that they can experience.
Thank you so much, Elena. I think we go, was there, oh, We skip that one for now, right? Yes. Great. So thank you so much, Elena. And it's so important to also look at different elements of cancer care and how we can support patients for the best quality of life and best outcomes as well in their care, and how nutrition plays the role in that. And the last but not least, the Ricky Alice, I would like to invite you now to share your perspective. So Ricky Alice is a global value stream strategy lead at Roche, where he leads technical customer centricity work and co-leads the global decentralized care initiative, which has already supported the launch of out-of-hospital administrative solutions in over 15 plus geographies to date. So Ricky, could you share with us what optimization of cancer care means to you, and what drives your interest in this space as well?
Yeah. I'm happy to, and thank you so much for the introduction, and thank you so much for having me. Fantastic to be here. I think to answer your question, which I'll get to in just a minute, maybe because I know my title probably doesn't mean very much to people in the room, I can give a brief introduction to where I sit and why I'm here. So I work within Roche's technical operations group, which is maybe an unconventional position to generally speak here. But what we look after is the supply, among other things, the supply of our medicines to the point of administration, and ultimately the design and manufacturing of our medicines that enable a lot of the choice that we're about to talk about. And within that context, I also lead an initiative that we call decentralized care, or in some markets, flexible care, which is primarily focused on enabling the delivery of medicine sort of when, where, and how patients prefer it. So I give that introduction to say, for me, what fundamentally drives my interest in this space, and it may be cheating a bit because it's in the title of this panel, is the concept of choice. And I think when we talk about patient centricity, you can't talk about that without an aspect of choice, because if there's no choice, it presumes that we know exactly what patients want, or it means that we're just generally designing for a very general population and not meeting the various needs that we just heard on this panel, be it once in a lifetime, hopefully things like COVID, or indirect costs, or nutrition, all these things that may lead to patient choice. So for me, what really drives my interest is the fact that now that we're talking about choice, we're really, and maybe it was mentioned in an earlier presentation where we said cancer care is not just a medical challenge. We're talking about cancer care beyond the pre-medical challenge of it. We're talking about it in a way where we can actually look at options that enable patients to live life the way they want to and take the choices with their healthcare professional that are sort of best for them in their situation. And I think the more we can do that, the more we'll find that, yes, it benefits patients, but it also benefits sort of healthcare systems at large and the caretaker community around them, which I'm happy to touch on more, but maybe I'll leave it there in terms of my interest in the space.
Thank you. So maybe I would like to directly follow up with you with that, because I'm quite interested to hear, having had an opportunity to implement some of these, I would say, non-traditional care solutions, what are some of the learnings that you take away from this space so far?
Yeah, I mean, I touched on it a bit, but I think, and it's so silly to say because I'm sure it's so obvious, but as we've implemented these programs, I think one of the biggest learnings and most profound learnings for me at least is that cancer care is not one size fits all. There's a lot of different things that impact the care and what patients want to get out of it. And through that lens, what we did through a number of learnings and iterations in the programs that we've done is we decided not to say, hey, we're going to work to implement exclusively something like cancer care at home or cancer care in this location. We're going to work on the concept of optionality. And optionality can come from incremental bits, maybe the ability to go from an IV to a subcutaneous administration, or optionality can go from other incremental aspects like moving the point of administration from an oncology clinic in a specific location to multiple hubs further out that are easier for patients to access. And when you start to introduce these aspects of optionality, that's when we find that a lot of the benefits that we're looking for, a lot of the response that we get from patients really comes from. So what we'll hear from patients all around is we so appreciate the ability to have care at home because it means I have more time with my kids. That was a direct sort of response. But the other thing we'll hear, and again, it speaks to the need for optionality and not one size fits all, is we'll hear other patients that say, hey, I would really prefer to keep cancer outside of the home. It's not it's not something that I want to integrate into my home life. It's not something I want around my kids. And I think that for me, the learning around not just choice, but optionality comes down to how do we, to the extent we can, provide options that make care for both those perspectives, regardless of which one is the majority, to be just as well taken care of. And I think that's really the bit, like I said, that gets me excited to be here and do my work, but also the bit I'd encourage us all to think about.
Thank you, and I think thank you for highlighting the element of patient choice and the option, creating more options for patients. And following up on that, Dr. Hadi, I'm thinking you talk about the integration of digital transformation as well, offering more options to patients in psychosocial and also educational support services, right? You touched on that a little bit at the beginning. Could you talk us a little bit more about how this, maybe you have some specific examples that you could share as well, where families or caregivers have experienced improved patient outcomes from this offering?
Thank you so much, Alex. Before I answer, can I just reflect on Ricky? Because this is actually, this is something that is now patient choices. I will share like a real life example what's going on now in Qatar. The moving of shifting from, let's say, IV sub-Q, and also now the shift where there has been feedback from the patient that they prefer, some of them, they get treatment done at their home. And we collaborated with the Cancer Institute, and now there is a 20 medication is being done at home, and we are jointly working on this project from funding perspective, support, and education. So now they just go with the home care services. Actually, what's the other thing? Your point is well taken. Let's say imagine in our region like a bus or a medical van has cancer logo on it. And people are going into that house. It's a big stigma in our region. So we had the idea of using the Hamad Medical Corporation home care, just home health care, and they just go in and that aspect. And it's really the optionality of what you want to do. You want to do it at home. You want to do it, and you want IV or a sub-Q. You want to do it yourself. And decentralizing treatment. Now we are moving into, the health, when I talk about the healthcare system, because as a Qatar Cancer Society, we don't provide clinical services, is moving, maybe some part of the treatment can be done in the primary care. And going back to the primary care, so we have like 37 primary care. So now there is a move, some of them, they will be doing part of the treatment, and some of them, they will be discharged for doing the transitional care. They don't need to come back to the oncologist. They will do the survivorship clinic. And even now there is a discussion of, because some of the people, maybe they don't want to come to the public hospital. Yeah. They want to go to private hospital. They want to be in a luxury room. And that's the discussion now, that moving the chemotherapy from public to the private sector is under quality inspection. So it's a very so the patient choices and even nutrition choices. I think I share that discussion. I remember one of the feedback from the people living with cancer there. We were talking about how they do nutritional replacement and nutrition supplement, and his feedback, his older adult, he said, "I'm sick of all sweet shake. Why they don't? It's all the nutritional shake. It has this sweet flavor." He said, "I want some savory. We are in culture, we like savory food. We don't like sweet food." So actually that question was taking, now we are collaborating with the entity in the US. I'm not going to brand, but they are working on nutritional snack and supplement savory for our region. So that's because it's their choice. They want, so really choices is very important. And regarding digitalization, so I would say I would start with the financial support, financial toxicity. So now we've been really fortunate with the support that we receive. We established an app. It's called All.Can. It's mainly all the process from healthcare professional to the billing to everything done, all the financial support through the app. They just submit all their papers. The healthcare professionals send their certificate and digitalize the whole process of the covering treatment costs for people that they need to overcome the financial barrier. And regarding education, like as simple as WhatsApp group, by the way. WhatsApp group is very effective, by the way. Really for patient, it's create a community. Yes, sometimes it's create problem. some of WhatsApp group, the patient just go out outspoken. They say, I did not like that doctor, and the doctor is already in the group. I mean, they just, or one of the nurses, they say reflect their opinion. So but it's effective. It's healthy. It's healthy. This is the other aspect is, a virtual support group. It's really is moving forward and getting more and more aspect. And now we are trying to add to the layer, by the way, of the financial support. We want to add layer. Whoever attend that work app will also receive, will be integrated into the psychosocial education system. And the last thing we are working on the education now is now we are having discussion with Microsoft and Oracle about developing AI persona for cancer education. So that's so looking into using artificial intelligence. We've been inspired by the WHO. They have this amazing persona, talk about NCD and tobacco and so on. So we're thinking seriously on developing, not a chatbot, a person, talk to you about in an attractive way how they can provide cancer education. Those are the most, this is the future initiative also, the discussion of the AI and education.
Thank you. And just for everyone here and online, I think you know how to use Mentimeter already. So the question of are PREMs and PROMs routinely collected in your country? So I'll just leave that up for a little bit longer. You've mentioned about patients also sharing feedback on the doctors. This reminded me, one of our World Bladder Cancer Patient Coalition member organizations in Italy, Associazione Palinuro, they created a platform which is essentially like a trip advisor for hospitals who provide bladder cancer care, and specifically bladder cancer removal surgery, where they evaluate hospitals on different parameters from a patient perspective, and patients can also rank things of the care, how many, there's some data to it from the data that's available, so obviously how many radical cystectomies they perform, etc., but also from patient side, how did they experience supportive environment, empathy, etc. So it's great that patients are also taking power and sharing that feedback as well with their care. I would like to come to you, Elena, just a little bit more on nutrition. Specifically, what difference can we make with medical nutrition in optimizing care and patient outcomes? You touched on that a little bit earlier, and I was wondering if you could just elaborate a little bit more.
Thank you, Alex. So, in fact, the idea would be, for nutritional care, or medical nutrition in this case, to improve the response to treatment, basically. So what it can do is to improve your health outcomes at the end of the day. So, and one important aspect I would say in this discussion is also on the decrease of the healthcare costs overall. Because in fact, if we have discussed many figures today, and if we touch on the costs in relation to cancer malnutrition, this cost yearly to the figures I have is for the European Union, it's 17 billion euros per year. So it means that if you instead invest in addressing nutritional care in the same amount, you would gain much more, right? So this would mean that the patient can respond. It doesn't have to interrupt the chemotherapy. It will increase, improve. It will have an improved outcome. It will maintain its weight, or gain weight, and at the end we can have a patient that is capable of facing its treatment, because it's not only malnutrition can happen because of the cancer, but also because of the treatment. And sometimes people die of hunger, if we can call it that way, instead of the cancer itself. So this is basically the bottom line. So this is, and we are currently partnership with the Cancer Patient Europe on that, so that to survey the gaps that currently exist in nutritional care across Europe, and in create knowledge informed choices to patients, not only, but also healthcare professionals. So there is also a lack of training within the healthcare professionals as well in terms of what nutrition can do to support the health status of patients. So, and this is another aspect that we would like to cover. And last but not least, there are really the policy initiatives behind are very weak, I would say. Sometimes there is a lack of reimbursement even because it's nutrition is considered a nice to have basically in the treatment, in the patient treatment journey, rather than a must have, because it will sustain the health of patients instead. And so we really partnership with the CPE to advocate for better nutritional care for all cancer patients.
Great, thank you. So I see the answers we have for this question on the PREMS and PROMS routine collection in the countries. The majority of the countries are saying no. It doesn't come as a surprise, and in the guide we also have it's a very big focus on this. I was going to say as well, I was hoping to see a slightly bigger number on the yes side, but as we sort of transition to the collection of these more systemically, I think it's also important to know that we use this also in the correct way, that we use this information to improve care and learn continuously, so patient experiences improve, and that the information that they have shared or have provided is not fall on deaf ears or is wasted. Just the last sort of few minutes, I know we're a little bit over time, but we started late, so I'll try to save a little bit more time, because I know otherwise everyone will be upset about the shorter break.
She's over there.
But Juan,
Just hide her face.
Juan, you spoke about the indirect costs so much, and just to follow up on that, because I think it's such an important part, when we look at the indirect costs that patients experience, did you see, or how could you describe it also, how does that affect treatment efficiency or care efficiency overall?
Yeah, thank you. Well, I guess the correct answer is that we don't know it. There's very little information and very little research about that, but it's very obvious that having so much cost directly to macroeconomy of the family, of the household, we need to understand how that change compliance with treatment, or how patients are deciding to modify their nutrition at home because all these costs are going to impact their macroeconomy in the household. So we know very little about that, but I guess that what was interesting about the results is that it's a very big amount, and I'm pretty sure that it's not only Mexico, it's across country, and it was also a very constant across the 5 different type of cancers that we identify. Basically, the numbers that we got is that per patient per year, it was somewhere between $7,000 and $10,000 per patient per year, only in indirect costs. And so for a family, an average family in Mexico, spending an additional $5,000 to take your patient to the hospital, I wonder how this situation influence all that spaghetti map that we're watching and all this process.
It's official now.
How is the spaghetti map is a word?
It's official,
Yeah,
that's
exactly.
it.
So how
it.
this economic situation that is not planned for the family affects that process, and what policies can be implemented to support the family in order to make more efficient process because of this additional financial burden on the family.
So I'm thinking now with that, I will follow up with our last point that I would like to have a call to action to each of you that Eduardo has mandated us to have from each of you. But just following up from this, because I'm thinking what you have just shared with us on a call to action to policymakers, but maybe perhaps to any stakeholder that you wish to think about, to take away from this discussion today and through the lens of optimization of care patient choice. What would be your sort of takeaway call action? Less than a minute.
My first call to action would be to understand better how these indirect costs impact, and in order to make policies that affect the 80% of the cost, because it's probably 20% of the problems.
Ricky, and then Hadi.
Yeah, I think my call to action would be, we need to collaborate and work together to design for the outcomes. And I think some of them in the action book are fantastic, but the outcomes being around greater patient centricity. And I think one of the learnings I didn't touch on, but to say it quickly, is sometimes I think it can be thought of as, well, there's care efficiency or there's patient centricity, and the other can be a luxury that comes at the cost of efficiency. But actually what we're suggesting is if we collaboratively design a combination of policy, capabilities, trainings, et cetera, what we're seeing is that they're not at odds with one another. They actually complement each other very, very well, be it directly in terms of cost or time savings by moving patients to a more preferred location, or indirectly, we've heard from HCPs and nurses that say, this is helping me better connect with my patients, and I really enjoy it, which is really important in a sort of overburdened ecosystem. So fundamentally, my call to action is, in this space, don't treat it as a luxury, and if we can design together against some of these common outcomes and common measures, I think it would be fantastic.
So for me, the point that call of action is we really, every country need to invest in improving the access program. Especially now we are moving forward into higher, more, now medication, target therapy, and the cost of treatment, it's, yes, getting better outcome, but the cost is higher. So really need to invest in working with all entity that they are involved, patient organization or nonprofit, the public-private partnership, to invest in that, to have a better access. And regarding that's my first point on improving access to treatment. The other aspect is we really need to decentralize people living with cancer education and psychosocial support from hospital, try to get it back to the community, and give them more choices to be able, and invest into the digital transformation so that people, they could have more and more, they can access the information they want, the time they want. And that's my, when I mentioned, it's when we do any educational activity, we usually ask, we do what's basic thing. We do need assessment. What do you want to learn? The same thing the patient. I meet the patient, tell them, today what do you want me to tell you? On what aspect? So definitely the patient has the right to know everything. But in every stage, they want to know, at the early stage, most of the, so I have just an example, so I know, but I want to connect it with a story. Head and neck cancer patient, advanced stage, they just receiving radiotherapy. All his concern was in the support group. I'm happy with the treatment. It made me eat again. That's it. Nothing mattered to the patient except that he was able to eat again. And he was, like, I see him during the support group on the WhatsApp or virtual, even face-to-face. Initially was very feeling down, but now when he reached a point that he's able to eat, that's all what's mattered to him.
And that's a beautiful transition for your final call to action for the table.
Thank you. So I have two keywords, perhaps. So, one is a sentence, and I think it's a bit of bottom line of why we are here today. No one can do it alone, right? Because I think we cannot say it's only for the policymakers or for the doctors. It's really everyone that needs to be involved and in a coherent and sustainable way. Where everyone plays his part and within its responsibility. And another, I think in my call to action, I really want to mention timely access. This was mentioned also by Ivana Cattaneo before. Timely access, I think, is very important, whether is it, early screening for the cancer itself, whether it is for malnutrition, whether it is for, treatment, post-monitoring, psychological support. The time we act is so important. So, and this shall go within this circle of, sustainable cancer care and patient-centric vision.
Thank you. And I would like to thank all my fellow panelists for your input. What I've heard a lot is about choice, about giving patients some control to the choices that they can make, and also the the importance of working together. And I think what stuck with me just from an earlier session, what Antonella Cardone said about the oncologists don't change, and I think the same attitude we can hear also from the systems and the policy side of things, or often no, that's not possible. And I think, I truly believe that things are possible. They are not easy, but we are not doing this because it's easy. We are doing this because we all want to make a difference to our patients. So with that, I would like to end our session. Thanks again to everybody, and thanks also to All.Can for allowing for this discussion.